Hello everyone and welcome to the Greater New York Dental Meeting 2020 virtual. I'm Dr. Gary Severance, Executive Leader of Professional Services for Henry Schein, and I'd like to share with you a program specifically on technologies that can mitigate risk in dentistry, some of them new and some of them existing. So if we look at this, what technologies can reduce risk for ourselves as dental professionals, our other team members, and our patients? And I've broken it into three categories. Technologies to make our office in general safer. We call it office protective equipment. Technologies that can reduce the visits and therefore the exposures to our team members and patients while keeping the same quality or better. And the technologies that can aid in documentation and tracking. All three areas are very important at this time, obviously. I wanted to assure you that this is going to be a fairly fast-moving program, and I'm very much aware of the attention span. A few years ago, they measured the attention span of the goldfish, and it was 9 seconds. They then measured the human attention span, and even now, this is pre-COVID or pre-Zoom meetings all over the place, it was 8 seconds. So you can pretty much guess every 8 to 10 seconds, I'll have a new slide for you to see and new information. The rest of this program is basically following, and I'm sure many of you have gone down the rabbit holes of looking at very interesting areas of our profession and gone deep into the web and tried to figure out things, because we have a lot of people and groups and organizations that are aiding us in providing recommendations, or in some cases, laws. So we're certainly aware of the CDC and what they do to protect ourselves and our patients, World Health Organization globally. We're bringing in the EPA now, more so than just mercury vapor and other pollutants that we have to look at. Certainly the American Dental Association and local dental associations have done such a wonderful job in providing recommendations. A great organization that has come up fast this year is OSAP, that's been around for a long period of time but deals with the sepsis in dentistry. American Dental Hygienists Association provided guidelines for their professionals as well. And because we're not only clinicians and having patients to take care of, we have team members, and they're covered, obviously, all of us by OSHA in the workplace, the FDA. And the one you may not be familiar with the most is ASHRAE, which is the Association about Heating, Refrigeration, and Air Conditioning Engineers. And so when we talk about air quality, which is one area that we can use make our profession safe, ASHRAE has been providing some guidance as well to environmental areas in general. Now, how do we make our office safer? And number one, is our office safe? That's a big consideration. And when you look at this, and we've probably all heard some of this data out there, dentistry as a profession, I often say it's the greatest profession there is because of the opportunities and the self-esteem that they can raise up in patients as well as health. But for the last 10, 15 years, when U.S. News and World Report has projected the best jobs in many different categories, dentistry has always topped or been in the top 100 job rankings. In 2020 already, they reported dentist is the number 2, orthodontist 4, oral maxillofacial is 9, dental hygienist 24, and dental assistant 66. And then on the other hand, we see another report that combines information on 968 occupations from the Department of Labor, and they categorize lots of dentistry as being the most unhealthiest profession. But I just wanted to clarify, because we've heard that term, but how do they get to that decision, and how do we explain it? Well, they looked at 906 occupations and ranked by 6 healthcare risks: exposure to contaminants, to disease and infection, to hazardous conditions, to radiation, minor burns, cuts, bites, and stings, and time spent sitting. So those were the 6 categories they looked at, and looked at all the professions and ranked them. And this is how dentistry made the top 4 of 5 professions. Only the vet assistant interrupted our streak. And you can see the hygienist, and as we've heard in many charts, is one of the, or the unhealthiest job, or some have called it the most dangerous. Dentist number 2, And you see they're listing only the top 3 of the 6 that they graphed, the top 3 health risks they had. And time sitting for both the professions are significant. Dental technicians are number 4, and they have time sitting. And what we all know, dental assistants are running around the office quite a bit more, getting patients, or at least they were, escorting them back. We may see this change next year if they do something similar with additional time sitting. And radiation is involved with all of the dental professions we're looking at here. And you may have seen this graph differently as well. And they've ranked it here based upon salary or income. And so you see very far on the right, which is related to significant risk. And in fact, they list the dental hygienist as the highest risk job here with a total score of 99.7. So interesting ways to look at it. So how do we make our offices safer and our team members at least assured of a safe environment? Well, when we look at specifically COVID or some level of protection, there's generally 4 disease transmission routes that are defined. Direct contact, hand-to-hand or handshake, indirect contact from fomites, which could be surfaces, droplets, obviously greater than 5 microns, or airborne. Spatter is also considered in the greater than 5 microns, but airborne, smaller than 5 microns. They can stay in the air longer. And there has been lots of discussion. Originally, we were dealing with, in this pandemic, washing our hands for that 20 seconds was the primary area. Now we're wearing masks and doing other things to reduce the droplet or airborne potential of it. And dentistry has always been very good at many of this. So with the advent, unfortunately, of AIDS, we've changed in the 80s to sterilize all the instruments to the highest level. Disinfection of surface contaminants within the dental office. PPE has been the big buzzword for 2020. And intraoral aerosol management. And we've done very good with high volume evacuation. Specifically on the PPE, it's something most of us had to learn about, is donning and doffing. And the CDC has provided very good diagrams that you have references, and now that you've been doing it for many months, in a whole nother category, I think dentistry has taken it up a notch. And we know before entering a patient room or care area, those are termed donning. And the list here, not to read them, but doffing. But for me, they were generally new verbiage that I wasn't aware of, so kind of did a little research, and some of these interesting things we may take it for granted, but what's the origin of donning and doffing? And so if you look it up, it's pretty simple. Donning is due on, doffing is due off. So an easy way to let team members and everybody remember this. And it was Shakespeare that was fond of the word doffing. But anything that can be donned can be doffed. So an easy way to remember which is which. But our next level of dental protection after all of this has now become focused on extraoral aerosol management, meaning after it leaves the patient's mouth, any of the aerosols that we create or the patient creates, and the indoor air quality of the office in general. And the goal of this, in ASHRAE, remember the group of engineers of air conditioning, heating, and refrigeration, they describe the chain of infection pretty well, in that the goal of it is to break that chain. And that's what they do with ventilation, filtration, air distribution, and disinfection technologies. Again, this is the engineers from air conditioning, the HVAC systems. But we can take this in and bring it more into dentistry. And although some companies have defined this over the years in dentistry, it really hasn't been to the forefront as it is today. Now, specifically, it's interesting to note, as I mentioned, we initially went after washing our hands and not contact. But back in January 24th, the highlighted case here, one person came into the restaurant asymptomatic and sat and ate with family members as well as friends. But many different tables were exposed to the virus. And so you see here 9 different diners became infected with COVID-19 or had COVID-19 afterwards, up to 12 days later. And going back and watching CCTV and the arrangement here, it's interesting to note the airflow in this room. So you see the AC unit is going there and the supply coming back. And people in direct line of that, obviously it was airborne because they looked back and the original patient didn't contact all of the other diners. And you can see table E and table F that are right next door weren't in the general airflow with that patient or the asymptomatic person and did not get the SARS-CoV-2 virus. And so when you look at that 9 diners at 3 different tables, so that was one of the first indications that it could be airborne. Also in South Korea, which has been one of the best at looking at this SARS-CoV-2 and reacting to it, they have a case study where 97 of the 811 employees tested positive, and you can see where they were sitting, certainly not all in contact with each other, but certainly airborne. And we know from some others, the goods and the bads. The choir practice where 87% of the group developed COVID-19, which is the bad, and started doing the 6 feet apart at least and wearing face coverings. And then we had a good indication of when all the clients and the 2 hairstylists all wore masks. None of their clients had it, even though they were infected. So we have these good stories and the bad stories, and we have to learn from both of them. And then just recently on 60 Minutes, you probably saw some of these diagrams also from NIST of a cough or a breath, and we stay 6 feet away because of it, but then we're also being told that depending on the airflow, it can be much more. And the wearing of the masks reduces that. So we have to take that into consideration. And then when you start to look at this in particular, especially in dentistry, because we have essentially all of these different surfaces in a dental office, and probably in our home. So when we look at the similar viruses to SARS-CoV-2, how long they can live on surfaces, New England Journal of Medicine and Lancet reported, we know from airborne up to 3 hours, typically in airborne. Printing paper, typing paper, it lives for that period of time. But we also see that copper and other, you can get up to a day with cardboard. That was one of the concerns of Amazon packages and opening them afterwards. But if you go way down, one surprising one is paper money. 4 days viruses can live on that. So it's real important for us to take this seriously, obviously, which we have, and take this and bring it into our practices and look at areas, whether it's new designs or new surfaces that we want to do, and certainly key to surface disinfection. And then we had lots of recommendations and essentially shut down to everything but emergency procedures or non-aerosol generating procedures. And we know the handpiece, the ultrasonic, and the air-water syringe can all create greater aerosols. There's also some discussion that the water we bring in dilutes that as well. So it's a good and a bad, but we know that we need to control it and when we use it. But it's not a black and white line because everything essentially is an aerosol generating procedure. Singing loud, talking, or sneezing is an aerosol generating procedure by the patient. And so we do have to take it into concern, not just stop generating aerosol generating procedures, but control the patient base as well. And we all know what the future of sports and the future of discussions might be in this or following this pandemic, certainly within it. Now the EPA, if you look at it outside of dentistry or mercury vapor, other things we've had to deal with, they have very clear steps in controlling air pollutants. And I think dentistry can follow and learn from this and make a very reasonable procedure and bundling. Infection control is a bundled requirement, meaning not one thing is going to do it all. You have to look at different areas, and as you bundle or layer these procedures, you can have better control of air pollutants. But when we look at it, they have 3 categories: source control, ventilation, and air cleaning. And they're in order of impact, meaning if you control it at the source, you may not have to do any air cleaning because we don't have air pollutants then. So the most effective, and ADA has recommended, as well as others, the efficacy of doing capturing aerosols where they're created or the source. And so you have the reemergence of rubber dams more than ever before. You have proper training on high volume evacuation. The studies have shown that we capture about 95% of the aerosols when HVE is used intraorally. And then devices like the isolite, which does a great job, if you can't have four-handed dentistry, of capturing a lot of the aerosol at the source or source control. But we also say just outside the mouth is also pretty close to the source, so you have seen probably a reintroduction of some of these devices into the chairside dentistry. They were popular in the 90s a little bit because of air abrasion chairside, so you would bring that over to the chair and capture it. And laser plumes and others. And some of these have emigrated from the laboratory environment into the clinical environment, trying to capture the aerosol as it is extracted or brought outside the mouth into the breathing zone of dental professionals. Typically, the patient is the one that is providing the aerosol, and if there are any viruses, providing that. But we also know pre-procedural rinses have been used, not only pre, but during and post, because a cough can bring it back into the airborne during the procedure. So all of these are the most important to do for source control. And then when we look at ventilation and air cleaning, not only do you have an HVAC system everywhere in your offices, circulating the air, which is critical, there's more and more of an investment now into local and centralized solutions, specifically on air purification. We'll go through some of that. And you can see that some can be inserted into the HVAC system by an HVAC technician. Others can be set in rooms, and based upon the size of the room and the airflow of the room, can do a good job of trying to purify the air. The benefits of air purification and ventilation are certainly of great benefit to not only the patients, the team members, but everybody in the practice itself. It's been proven in and outside of dentistry and other corporations. It increases productivity, decreases absenteeism by reducing some of the risk involved. So there is benefits to making sure the air is purified as much as possible, and ventilation is included. Now, how do they purify or use this filtration or inactivation? Those are the two ways most of the air purification systems work. They either filter out the particles or they inactivate the viruses, bacteria, and other areas through chemical or technology. And many of them use a combination of both. Now, one thing I do have to stress is probably many of you went out to Amazon, or went on Amazon, went to Sam's Club, Costco, others, and simply bought air purifiers to prove that you were taking care of the patients and cleaning the air, so they can visibly see that. And that's fine, but primarily these are consumer units. And there's a little difference between a consumer unit on how well sealed it is, how effective it is, compared to some that are specifically for medical, dental, or private offices. And the difference really is your dental office is pretty unique versus your home or a person's home. You have many rooms that have many different aerosol generating procedures, different surfaces. Air circulation is probably a little more limited than maybe in a smaller home. But you also look at new patients and new breaths and new air coming into your office every 15 minutes. Whereas at home, you typically have your family and not necessarily somebody coming in and leaving every 15 minutes. So you probably need to look at a little more professional level of protection and a well-sealed and a well-contained air purification system. Now, when we look at air pollutants and the different sizes, you know, it can go up to pollen, very large at 250 microns. Human hair is between 50 and 70 microns on average. You can go down and look at all of these and how they slide down into the sizes. And there's one particular size of particles that's the most difficult to filter. And that's important to know because they call it the most penetrating particle size when you talk about filters. And that's at 0.3 microns. Now we know that's right where the viruses start. Something like the SARS-CoV-2 is about 0.125 microns. So it's smaller than that. But it's interesting to note that the most penetrating particle is right at that 0.3. Why is that important? Well, filters will capture particles on either side of that most penetrating particle. And it's fairly easy to understand because that particle size kind of flows with the air. And air will go through air filters, as you know, and sometimes those particles stay right with the air and can get through, whereas smaller ones will be caught and larger ones will be filtered out, and the majority. So when we look at filtration, I think we're all familiar with what's called the MERV filter. This is what you have in your HVAC system typically. They have MERV ratings, minimum efficiency reporting value, from 1 to 20. The higher the value, the more efficient it is at filtering out particles, especially the 0.3 microns and higher. And you can see if you go to Home Depot or Lowe's and buy a MERV filter of 17, you're capturing quite a bit, but the air is restricted more, and your HVAC system may not be as efficient, or you may not get enough air through that. So you may want to do, as a first step, to look at and contact a HVAC technician to come out and say, what's the highest level of MERV rating can you put in your office to capture the most air pollutants without restricting the air? Typically, it's in home use 6 to 10 rating. And then we had a lot of recommendations, and the CDC, one of the engineering infection controls they recommended, is the use of a portable HEPA air filtration unit. And while we may have heard of HEPA filters before, and some of you may have always done this, this is specifically brought to light. If you had a Roomba that has a HEPA filter in it, a little more filtering possibility, but it takes it a step up from HEPA filters. And so when you look at HEPA, high efficiency particulate air, those are the most common filters used in air purifiers. And they capture, it's typically one level, although you can find true HEPA and others. You need to read between the lines a little bit and research it again. But HEPA filters generally do a very good job at capturing the particles that are 0.3 microns, as well as smaller and larger. And if you read some of the CDC guidelines or some of the articles, you find out how they capture it. They capture they're basically fiberglass fibers, a mesh of them. The air goes through. A particle that's larger than the gap between those fibers will get caught or strained. Particles that just collide to those glass fibers will stick. The inertia, this is where air may take it and make a turn, but the particle can't, so interception. And then diffusion, and I just want to graphically show you with this little video the concept of diffusion. So here we have a smaller particle than 0.3 microns, and you can see it flows erratically. This is how viruses or smaller particles can be stuck to these fibers. So don't think that everything goes through that's smaller than 0.3 microns. And you can see it doesn't flow smooth with the air like a 0.3 micron. It would get stuck. So you can capture smaller particles. There is something you also may hear about is ULPA, ultra low particulate air. And that's a very tight weave, essentially. It is much more restrictive on the airflow, just obviously because it allows you to capture more. So normally you'll need to purchase an air purifier that is made for an ULPA filter. You just don't want to take your HEPA unit, take out the HEPA and put in an ULPA, because you won't get the adequate airflow that you need. They're also about 35% higher than HEPA and a shorter lifespan, simply because they get clogged faster. So again, the CDC recommends looking for, and most of the consumer as well as the professional ones have a filter. There's also something called a pre-filter that they put in front of a HEPA, which is like a screen door or a screen on a screen door. It captures some of the larger pollen and others and extends the life of the HEPA filter behind it, if that makes sense. Those you can clean and reuse. The HEPA, ULPA, and MERV, it's a consumable, so you have to change. And most of the units tell you when it should be changed. Another one that physically can capture the odorous, gaseous, liquid contaminants, adsorbing those chemicals, reduce ozone, is a charcoal filter. So normally you may have a matrix of these or layering, a pre-filter first, a HEPA filter, and then a carbon filter. And as the air goes through, different chemicals, different pollutants are captured at each stage. That also needs to be replaced and can get clogged fairly easily, but that will clean or give that good gas, get rid of the odors and the gases. Those are the filters to consider. When we talk about inactivation, One of the most popular ones you'll hear and mentioned at the CDC as well is ultraviolet light. Several ranges within, the ones ranges within UVC light. We're talking UVC. There's also in the future talking about a lower level even than that. That is not dangerous to the skin or eyes. UVC is. So if you utilize this, it's called ultraviolet germicidal irradiation. It inactivates microorganism by damaging the DNA and RNA. We're a microorganism essentially, and this light can penetrate the outer layers of the eye and the outer layers of the skin, so we can have damage. So you want to have this shielded within a system where the air flows, or used when no one is present. Also important to take note that you need a dwell time, so air can't flow past these bulbs and be disinfected if the air is flowing so fast or the light is so low in wattage, or the air doesn't get close to it. So it's a little difficult unless you have lots of UVC or lots of additional things to say that this is really helping any of the air that goes through filters in inactivating. The CDC did also say you can consider the use of upper room ultraviolet germicidal. They keep it up there so it's away from exposure to the humans. But the particles, again, have to get right next to it in order to be inactivated. So there are some other solutions to use. A combination of UVC or UVGI and a titanium dioxide catalyst not only has the benefits of UVC, which we talked about, but also can then create highly reactive hydroxyl radicals in the air. And this is almost like a bug zapper. When you create these hydroxyl radicals, they then can oxidize or burn and just leave residue of water and CO2. Very clean, but it can deactivate, again, VOCs, viruses, bacteria, and toxins by zapping them in the area. So another additional method of using UVC with this chemical or catalytic oxidation. And you can see some combine photocatalytic oxidation with filters, or you can do it locally and place units in a state that send out these radicals, or the air passes through these radicals and put them within the HVAC system. So two opportunities for you, locally or centrally. And then you have what's called ionization, and there's several different areas or levels of specification for these, but it's essentially creating electrons, negative ions, and positive ions. And in fact, most forms of pollution and chemicals have a positive charge on them. So the process here is these negative ions go out and can agglomerate on these larger negative forms of pollution and drag them to the surfaces, drag them out of the breathing zone. And so you see negative ions outweigh the positive ions, and they create clusters and can bring the particles out of the breathing zone. This is very natural occurring, having negative ions. It's after an electrical storm, near the sea, rivers, and waterfalls. So it's very natural and safe. Again, they can be used throughout the entire office through HVAC system and give a little positive energy with negative energy. Another trivia for you is where in the world is the highest level of naturally occurring negative ions. If you have ever been to Niagara Falls, that's where it is. So you can see a lot of negative ions there. It gives it very, very fresh. And as I said, you can use these locally in some of these systems, have ionization, or put these in centrally into the HVAC system and create it centralized. Based upon the square footage of your office, it may be one or two in the HVAC system, or one of the little locals in each room. And as we discussed, so we've gone over filtration and inactivation. We can also look at how they're combining them. So we have one on the left, an extraoral aerosol suction device, which has a cotton filter to take the moisture out if you're going from top to bottom, a fiberglass or HEPA filter, a carbon filter there, and then it goes down into where the fan is and suction and UV light. And then it expels the air at the bottom. So it's trying to do multiple ways to disinfect or purify the air. Another one, the one in the middle, comes up from the bottom, so it drags air out of the breathing zone, Goes through a pre-filter, a carbon filter, a HEPA filter, and up through a reaction changer that is loaded with UV light and photocatalytic oxidation. And the air coming out on top is very unique in that a single air pass, 100 or near 99.999%, is purified. And then we even see some ceiling mounted units where they have a MERV filter, then parallel along a UV light to try to get the air close to the UV light. And then I'm sure you're all aware of the EPA List N. It's an app you can get as well to see what the EPA has said works on the SARS-CoV-2 virus. There's 6 different categories. 2 in particular I want to mention because they are becoming popular in fogging. Hypochlorous acid, electrolyzed water in other areas have made some good applications here, and some good articles have been written and some great webinars provided on it. It's kind of nature's disinfectant, and it's essentially salt, vinegar, water, and some electricity. So you can make it yourself and do this. And when they look at the review, there's been a couple in the Journal of Oral Maxillofacial Surgery, 2 dentists, I think they're GPs, but presented the information and did a good overview of this. And as you can see, some offices are fogging with it. So they can put this into an office in between patients. One person, Dr. Leslie Fang, physician, has done incredible work. I'll give you a couple websites to look at. You can make your own solution. You can have essentially a fogging system and fog the rooms in between patients. In China, you'll see school children get fogged prior to going into the school. And lots of opportunities to look at that. And so here, starfogging.com or the new.dentist.com did a very nice comprehensive overview of how fogging or hypochlorous acid can be used in dentistry. Another one to look at, and this is pretty interesting, airlines are all fogging. This is a quaternary ammonium process that American Airlines is doing, and they do it every 2 weeks. What's interesting here, it's only approved for flights departing Texas, and where the comment is apparently chemicals are safer in Texas since the EPA did not approve it anywhere else. So it's called surface-wide. But if you're flying, you probably will have your airplane fogged either in between like Delta is doing. They are using hypochlorous acid here. And what it does is allow you to get surfaces that normally you would never wipe down and make it for these areas are the most efficient they can with disinfecting these surfaces. And Dr. Leslie Fang, again in his webinar, also kind of gave you ideas. You end the case, you clear the operatory. That should be fogging, takes about 5 minutes, wait 10 minutes, which then matches what the CDC originally said. Then go in and wipe the surfaces down as you normally would. And the ultimate, as we continue to hear, is a negative pressure room, which brings new air in from the outside, clean air, and expels all of the air in the room out, and preferably outside or through filters, as you see here. It's essentially creating a negative pressure, so air is sucked in and then blown out. That can be difficult in many established dental offices to integrate, but something that could be considered on new builds or upgrades as well. Especially if you are doing most of your aerosol generating procedures in one area or one room. We touched a little bit on this, and I mentioned that some of the studies, you really have to go back to the 90s or early 2000s when they used these primarily for air abrasion units. And some areas of the world are more interested in it previously as well. So you see these devices that essentially capture as much extraoral vacuum aspirators, what they're called in this category. But if you go back, it's 1995 or 2001 when you see most of the data. There was a study done in 2010 by the British Dental Journal that used a similar device, the IQ Air FlexVac. And what they did in 3 different clinics, different patients here, so it's not relative, each bar isn't relative to each other. But they did an aerosol generating procedure, a cavity prep, and they had it with this ACS, air cleaning system, off, and measured the colony forming units, cubic meters, away from the patient. And you can see fairly high. And when they turned the machine on, the green bar came up. So it did reduce it considerably. The second column is non-aerosol generating procedures. So that one was an exam in history not using the air water syringe. And what they saw there was no difference with it on or off. So it kind of fell into place. Then they did ultrasonic scaling, again, not relative to the first one, but on its own in a different clinic. And they saw with it on or off made a significant difference. And even a tooth extraction, they had less colony forming units with the system on. And you can look at different systems, read about them, look at their filtration methods, and if they use chemicals or if they use UVGI. A lot will be combined in different systems. That's what they look like. And then you can also look at localized air purifiers, which come into play. They sit in a room. You need to know how the airflow is, how cubic feet per minute, and look at, they have different filters. Take the JADE by Surgically Clean Air. Uses a HEPA, a MERV, a carbon, UVGI, ionization, and photocatalytic. So just about everything we talked about. Others, simply use these filters and draw the air through the filters as well. So take a look at that. When you start looking at this, you want to know the methods that they're using, and if the UVGI is strong enough to really make an impact, or is the airflow flying through so far. Cubic feet per minute with that as well. And the size of the room is probably in cubic feet ideally, because the ceiling comes into play. And you can match that to the speed of the air that you want to move through, or the capacity of the filter itself. And there will be a calculation you can do called air change rate, or how often are you changing the air based upon the cubic feet per minute and the size of the room. The sound level, these are on most of the time and recommended to be on most continually to exchange the air and purify the air. And operational costs over time, because there are filters to exchange, there are bulbs to replace. The other thing that's difficult or you need to should take into consideration is most of these consumer and professional air filtration systems recirculate the air. And they don't capture everything on one pass. And so it may take 30 minutes for the air to be gone through several times through the filters to get up to that 99.97 purity, or longer. Or if you bring in new air, it may take even longer. There is a system that I'll share with you that has proven in a single air pass, meaning all the air that comes through is devoid or not detected viruses and bacteria in just a single air pass, and I'll explain that. The calculation you use to see how many air changes per hour, right now it's about 6 to 12 that ASHRAE recommends, but here you can see on a low speed, I get 9 changes per hour in a room that's 10 by 12 by 8, and you simply take 60 times the air speed, or cubic feet per minute, divide it by the cubic feet. So if I have a 10 by 12 by 8, that's 960 cubic feet. That calculation is 9. If I turn this up to the highest airflow rate of 383, which may increase the volume a bit or the decibel level a bit, but I get 24, which essentially, if it was a perfect condition, would change out the air and you had good airflow nearly every 2.5 minutes or so. So pretty incredible opportunities for you to do this. And as I mentioned, you can get some either with ionization or photocatalytic oxidation that are installed into your HVAC system so it can take the air for the entire office. And what I wanted to reiterate is recirculation versus single air pass. Something to consider. These all recirculate and take time. So it may come in and get some percentage of the pollutants out, but then it blows back anything it didn't get back into the air zone or back into the area. So it takes time for all of these systems to recirculate the air and eventually get to their highest level. And when we look at what that means if you put one of these units into a system, it may be 30 minutes before all the smoke or the air or the pollutants get up to that 99.97. So it doesn't do it, so it essentially recirculates pollutants until it gets it all out. Bringing in new people or new odors or pollutants then will take that even longer. There is one system that the air comes in at the bottom, and by the time it comes up, it goes through the reaction chamber, and essentially 99.999% pollutants are clear from the air as it goes back into the breathing zone. And it was created, that essential technology called VirusKiller Technology was originally funded by the South Korean government in response to the SARS 2003 coronavirus. It was done by the government and universities. They saw a special need at that time and already has over 370 commercial installations, over 80% of all universities, hospitals, and 70% of health centers. And it has what they call a single pass kill rate of 99.9999. So no recirculating. And when they tested it, there was actually no detection. They have not, which most have not been able to test against coronavirus SARS-CoV-2, but they have done other SARS corona-type viruses and found no detection. The same with bacteria, fungi, and mold. This is what those systems look like, companies Eradicate. But again, they're talking about VirusKiller Technology. They have it for large waiting rooms, open clinical design, another one for operatories or even small waiting rooms, and a small one for front desk or small offices as well. But it's important to know how they go. The bad air essentially comes into the bottom, and by the time it goes up the top, they control the speed of the air so it has that dwell time within that reaction chamber. So it's not as fast as it can be because it wants to be effective. So you'll see various filters and that reaction chamber, which has photocatalytic oxidation, quite a number of UVC lamps, and a lot of titanium dioxide. So what this looks like in a waiting room would be like this. And you can brand it if you want, put your practice's logo. The one for the operatories work well because it has very laminar flow against the walls. Again, you place this typically at the foot of the patient to draw air away from the breathing zone of the dental professionals or the patient themselves into this area, and then it will expel clean air, again that 99.9999% clean air, off the sides to a laminar flow, which then effectively runs all of the air in the operatory through that. Again, it's lower speed, so it's not as big a space, but you can see it in a high-tech office, at seated or wall-mounted, at the foot of the patient, can be between operatories as long as you consider where your airflow is now, or it can be on a TV stand at the foot or mounted or set on a table as well. So some interesting options. And the smaller one, again, has the same effectiveness as the larger one, but just in a smaller square foot. When you take a look at this, all offices and needs are different. Square footage, office design, environment, patient flow. Team members create their own airflow, so you really have to look at what the airflow is and how many aerosol generating procedures you do. Otherwise, you look at bundling infection control. Don't just stop at source control. Look at some other procedures of the air ventilation and air cleaning. The second technology I wanted to do are technologies that can reduce the number of patient visits. And so we all know our job in dentistry is to make beautiful smiles, healthy and functional smiles, and get better health. But behind a lot of these great looking teeth are a lot of restorations. And normally these are done maybe in 2, 3, 4 appointments or at different time periods. And there are some technologies that you will see talking about reducing the aerosol generation. Now you can do that by using different technologies. This is Solea, all-tissue laser that is showing data with HVE that they're creating less aerosol. We all know that lasers create a plume, which essentially is an aerosol. So you still need to take into consideration, but they've got data, and you can check their website out, showing lower than handpieces. And if you are not aware that these lasers cut, it's pretty impressive. These all-tissue lasers can do that lots of times with no anesthesia, and it does cut hard tissue very well, different than in the first generation of lasers way back when. And then we look at an area I'm very adamant about, is digital dentistry. It's one thing to try to not create an aerosol, but it's another to not create that aerosol or hand it to a laboratory. So if you picture how you're taking a conventional impression, you're typically taking it out of the mouth, taking an air water syringe, and maybe within our breathing zones, using an air water syringe to dry off the saliva-laden impression, which is now creating a second level of aerosol. And then if not disinfected correctly or placed in a bag that may have some remnants of the saliva, now we're transporting that saliva and essentially an aerosol if it gets to a laboratory who's now redrying that impression out. So I think it's better and a good consideration. There's a wide variety of scanners that work very, very well, but now we can sterilize the tips and not really pass any saliva. Yes, we have to use air water for drying, but the days of maybe passing materials from a dental office to a dental technology can be reducing the amount of transfer of materials. And then when you can look at chairside mills or printers and provide solutions in a single appointment, we've reduced the number of visits and the risks in half. If we did something in 2 and we had the patient come back to get it seated, that's twice the risk and twice the exposure to our team members and to the patient of something possible. So look at areas that can reduce that. And I like to talk about digital dentistry being a capture, customize, create procedure, and it's something you do every day. Here's Sharon Siegel, professor at Nova, a prosthodontist, but it's wonderful to capture her image, which we do with so many products, customize it, which we can do with software and make any image we want, but then we typically create something. So we do this every day in our personal lives, and we can do it in dentistry and do it. And we have so many different areas of capturing or technologies that can capture it. Using extraoral bite wings on some of the 3D units, again a recommendation that was provided to eliminate the risk of intraoral gagging or coughing by patients. So these are all capture devices. Extraoral bite wings, as I mentioned, is a possibility with extraoral devices, and this has become really the new mirror of dentistry. Instead of just remembering what the mirror looks like, take a scanner and capture it and record it and keep it over time. It certainly gives you documentation that we've never had before. And the scanning innovations continue to change. Check out what's new with your dental distributor. Get hands-on with it, feel it, how does it work, comes in all shapes and sizes and effectiveness. And scanners now, although not FDA approved for many of them, are starting to use different technologies with different tips to show different areas of dentistry than just the surface, so you can take a look at that. And other technologies are taking dentistry to new levels by capturing the extraoral environment very nicely. So here's an app. I've sped this up a little bit. That's Dr. Lita Swan at UNC. Bellis 3D is an app on your phone that you can use to capture the 3D environment of the patient extraorally. And so now you have just a beautiful image. Some of the 3D systems also have face scanning as well, but this is a simplified system. And then once you have the data, you can customize it. You can take that, you can design a smile, you can design a surgical guide, restorations, even the placement, place the implant before you even cut tissue. So all of these in dentistry allow us to do unique things. If you did that face scan, you can bring that on board in some of these lab softwares and really compile it and see dentistry like we haven't seen before, along with reducing the risks and exposures and allowing the dental technician to use the information you've provided. And then we have to create things, and the 2 modes of creating chairside, let's say, are printers and mills. And there's a variety of those for you to check out. And most of the mills that you'll see really grind with either 2, 3, or 4 burrs in some cases. And you see it's a reduction of the block. Now the block is very good because it's non-porous, and a very solid type of material. And you have different areas of milling that down, and you can get some great precision. There is new technologies coming from one that uses it differently, that actually has the block move. And the statement there is the burr stays in contact, just one burr stays in contact with the block and not creating as many microfractures. But you'll see different technologies come about. The main thing, more and more, are going to handheld applications, no touch for that area. So you're able to take a tooth, prep for all ceramic restorations, try in the restorations, customize, and then seat it the same day, reducing the number of visits. And certainly one in particular has a very fast milling of zirconia, so now that's much more possible than it was previously to do even zirconia restorations in a single appointment. Now printers, what we're doing with printers allow us to do a lot of things faster and easier than before. Many different materials, dentures, aligners, wax-ups, guides, guards, bonding trays. And again, they're starting to use more and more apps that keep the hands away from these procedures and can manage it differently. And what's important to note is this market is not going away. It's already worth $780 million in the dental market in 2018. That third bullet is pretty unique. Most of the printers were in dental laboratories in 2018. In 2027, it's predicted more will be in dental offices to provide immediate efficiency. And you can see it's predicted that 60% of all dental product needs by 2025 will be printed. Pretty unique. And then finally, how do we do technologies that document and track? Because we need to take care of this. We need to track who's doing what in infection control in our offices, what has been done. If a patient comes back, we need to be able to track where it was. There's some air purification systems that may tie particle counts to when the patient was there, so we can see the level of air purification. But there's a great area, and it's a free application that I wanted to share with you from Health First. Again, it gives you the opportunity to track and assign procedures within your dental office, so you know things were done each time the right way, whether it's greeting patients, whether it's changing gowns, whether it's emptying the garbage, whether it's doing this. So this is called OnTrack, and you can quickly set it up. I'm not promoting it because it's nothing from an expense standpoint. It's free. So what you start with is an app that's on phones or your computer. You can go in and set the days and times of your office procedure. You can start laying out the infection control and cleanup. You can add your team members and their email addresses or phone numbers, what areas. This is documenting all the areas that you need. And then you can define what the considerations are. The pre-screen of patients, was a temperature taken? And when they arrive at the practice, what days and when do we do this? You can then assign team members this in your practice. They get notified to complete and document that they completed it. It's all digital. You can have access of the tasks at any time for a patient. We can see when they're due, the sharps container, fill level, have they checked it and done it. It's a very good job, and you as the administrator or your office administrator can look at all of these different areas, who is assigned to the due date and the completed date. If there's weekly assignments, whether it's changing filters, cleaning, water, vac systems, you can put all of this in. So great area. If you want to go, you can go to the Health First website, go to OnTrack, and then control down, use your Henry Schein customer, and get a free application. So again, I want to thank you for staying tuned with this. I appreciate the opportunity to provide you all of this information. Obviously, things change all the time, so reach out to your favored distributor to check on the status of products, what's new and what technology. Continue to do better dentistry every day, maybe with less visits and less risks. Again, thank you very much for your attention.